I can't imagine, so this was the Presidential Symposium. I can't really imagine a more difficult transition from the last 20 minutes into a Presidential Symposium. It will feel like punishment, but in any case, thank you for all those who decide to stay. And this is the opening of my Presidential Symposium, titled Access to Health Care in Low and Middle Income Countries, Challenges, Barriers, and Solutions. So here is how it's going to go. The principle is simple. We put together, within my presidential term, a goal that was to address a fundamental injustice created by a lack of access to basic education and medication that can improve the lives of headache sufferers in underserved communities. The mission based on that is simple. It's driven by a medical and moral imperative that when patients have no access to care, we must do something about it. So, putting this together, how did we begin working on this? So, we put together a questionnaire that will give us really the first clue, which is very different from lifting the burden, on what are the true challenges that we identify in low middle income countries. We started in 35 countries. 32 of them we did with Daria Olduz and Ainur Ozga, who delivered questionnaire, and we chose out of these 32 countries 5 to be presented here. And we took another 3 countries that we were involved independently. So with this, basically, we are starting this presidential symposium by giving you a flavor for the true challenges of access to health care in the Philippines, Azerbaijan, Egypt, Nepal, Moldova, Mexico, Mongolia, and Kenya. First, I would like to ask all the speakers on this list to come here to the stage. There are a few things that I want to say. First, when we chose the speakers, we realized that we are giving voice to speakers in countries that never had a chance to speak in any of the International Headache Society meetings. That's a good part. The difficult part is that 3 of these speakers from Nepal, Mongolia, and Kenya could not join us. The speaker for Nepal, Dr. Raj, got caught in the rioting that shut down the airport in Kathmandu in the last 72 hours, and there was no way for him to leave Nepal. The representative from Kenya could not get a visa to get here, and Dr. Odgenbayer from Mongolia just couldn't make it. So unfortunately, I'll have to briefly present the data. I can't possibly do that, but we're going to go through the program, and we will try to cover it. This is the first part of the program, to try to give you the feeling of how huge is the challenge to create access to health care in low and middle income countries. And the second part of the Presidential Symposium will be devoted to answers. How are we going to implement it? So we're going to start with right? We're going to start with Dr. Corey McAlintal, who is the head of the headache clinic and the outreach program in the Department of Neuroscience at the Asian Hospital and Medical Center. She's also an IHS coordinator for the Philippine Headache Society, and I'm sure many of you have not heard about her until now. I'm going to let her present the Philippines.
Good afternoon. I would like to thank IHS for giving us the opportunity to present access to headache care in the Philippines. I have nothing to disclose. The Philippines is geographically made up of 7,641 islands divided into 3 major regions, Luzon, Visayas, and Mindanao. And they're separated by water that creates challenges in connectivity and communication, and resulting to an equal challenge to goods and services between islands. It has a population of about 109 million in 2020 and is now at around 112 million. Research in migraine prevalence in care has been very limited in the Philippines, so to better understand its status in care, here are the 2 surveys that were conducted under the initiative of Professor Burstein. The initial survey focused on the healthcare workers and to validate the findings and provide a more comprehensive view of migraine status in care, a community survey was subsequently conducted. Health workers from all regions of the Philippines participated in the survey, with the majority of respondents coming from Luzon, which is the most populous region. The community survey was likewise conducted across all regions, with the number of respondents proportionally aligned to each region's population, ensuring the closest nationwide representation. Again, majority are coming from Luzon, Metro Manila, Region 4A, Region 3, which are the most populated regions in the Philippines. Here are the distribution of the respondents by healthcare workers, showing nearly equal proportions of doctors and non-doctors. For everyone's information, we have barangay health workers who are actually lay health workers in the Philippines who serve as the front line in the primary healthcare at the village level. They are not doctors, nurses, nor midwives. Instead, they are trained community members, usually volunteers, who are trained to assist in delivering basic health services as per the Department of Health program. The prevalence of headaches seen by healthcare workers were at 24%, while migraine prevalence was at 11%. In the community survey, where we made use of the ID migraine screening tool, migraine prevalence in adult was 19% and teens at 15%, and an average of 70% for headache prevalence. That brings us an estimate of 78 million Filipinos suffering from headache and 21 million Filipinos with migraine. An important observation also in this study is the higher prevalence of headache reported in the community survey compared to that of the healthcare worker. This finding suggests that a considerable number of patients with headache may not be reaching the healthcare workers. In the community survey, half for teens and half for adults, with the headache and migraine prevalence slightly higher in adults than teens, as mentioned. Headache and migraine were also found to be more prevalent in females. This slide illustrates that although headache and migraine patients affect many with higher education, more than 60% come from low-income household earning less than $21,000 per month or around $368 per month. With an average household size of 4 to 5 members, this translates to less than $2 to $3 per household member per day budget. Who gets to treat them? From the table on the left, you will see that non-doctors, as barangay health workers, midwives, and pharmacists, see 2 to 3 times more of headache and migraine patients per month than the doctors and the specialists. In the community survey, nearly half of patients do not consult a healthcare worker, indicating that the cases seen by the healthcare workers represent only about half of the actual headache and migraine burden. The top 3 reasons for not consulting a doctor were the following. Of course, expenses would be on the top of the list. Now, how about the training backgrounds of basic health care of the healthcare workers patients see? Headache specialists and the neurologists are the only ones who would have a formal headache training. Other healthcare workers rely on brief conference sessions and workplace encounters, while barangay health workers learn more about the headache care only from occasional lay fora. And so, if we depend on neurologists and headache specialists, We will have one urologist for 12,000 to as much as 800,000 population. With our population at 112 million, there is one urology for every 223,000 Filipinos, one urologist for 156,000 headache patients, and one headache specialist for 4.4 million headache patients. As for migraine, there is one urology for every 42,300 migraine patients and one headache patients for 1.2 million migraine patients. Now, how about the primary care level where most patients should be benefiting from? The Department of Health, in line with the Universal Healthcare Law in its initial implementation stage at this time, has set a ratio of 1 doctor per 20,000 individuals and 1 barangay health worker for every 20 households. In the current situation, though, there's 1 barangay health worker for 110 households to as high as 1,250 households. There are also not enough doctors to meet the required population ratio. In fact, the Department of Health had to establish the Doctors to the Barrio program to augment the supply of doctors in the underserved communities. Since most patients are not assessed by adequately trained healthcare workers in basic headache management or did not probably even see one, migraine medications remain underutilized. Patients are just using or being given analgesics and NSAIDs, with opioids, specifically tramadol, being used more than that of triptans. And even if doctors prescribe triptan, only few patients use them. As for preventive treatment, about 81% of patients were not given nor even informed of preventive treatment, even if around 13 to as much as 80% likely need them because of frequent attacks and impaired work performance. 98% of the healthcare workers are not aware of preventive treatment, and only 50% of doctors, primarily neurologists, give them. Patients currently pay the full cost of headache medicines since headache and migraine are not part of the Department of Health priority program and thus not included in the free medicines that they're supposed to give for free for patients at the health center. Unfortunately, the survey showed that around 60% of patients could not afford to pay the medicines. While the Philippines have access to almost complete range of acute and preventive migraine medicines, affordability remains to be a major barrier. As mentioned, more than 60% of our migraine patients come from low-income families, surviving on less than $2 to $3 per day. And for them, a single triptan tablet can already consume at least half, if not all, of their daily budget, making effective treatment out of reach. The same struggle is true for most preventive treatment, leaving migraine patients trapped in a cycle of pain without proper care. So in summary, majority of migraine or headache patients are not seen by headache specialists because the numbers are just not enough for all patients. Patients' first stop for consult would be the primary care facility because of expense, time, and accessibility, and it should be equipped with basic headache care. And although headache medicines are available, they remain underutilized because even when prescribed, majority of patients could not afford them. We recognize these many concerns and gaps in migraine care, but with limited resources and logistical challenges, our capacity to act has been restricted. The Philippine Headache Society with the Headache Council of the Philippine Neurological Association are working together to increase the awareness and strengthen the knowledge on headache care with conferences, workshops, sessions, and lay fora. In addition, the Headache Council of the Philippines is working hard to finish the first clinical practice guideline for migraine targeting the primary care physician. Through these initial efforts, we hope to engage the Department of Health to include migraine in its priority program and assist us in achieving better headache care for everyone. With those being said, we are very grateful that International Headache Society, Professor Rami, for including the Philippines in its program to advance access to headache care. We are truly honored to have given the opportunity to present our situation and be part of this important initiative. And would like to thank you for putting the Philippines in the map of IHS. These are the people who are working hard in the Philippines for a better headache care.
We are moving from here to Azerbaijan, which will be presented by Dr. Sarkan Amir Gulaev. He is a headache specialist at the Azerbaijan State Institute of Advanced Training of Doctors. Much of his training in headache was completed at the Danish Headache Center in Copenhagen. Please.
Dear colleagues, it's an honor to present at the International Headache Congress and to contribute to the Presidential Symposium. Today, I will share our findings and access headache care in Azerbaijan. First, I would like to thank all my colleagues who contributed to this important project under the expert leaderships Professors Aynur Özge, Derya Ulduz, and Rami Burstein. Azerbaijan is known as a land of fire for its natural gas flames. It sits on the historic Silk Road with landscapes ranging from high Caucasus speeds to subtropical lowlands. A true crossroads of civilizations and beautiful place to visit. The capital of Azerbaijan, Baku, is a modern city that showcases a mix of futuristic architecture and historic sites, included the old city, which is listed by UNESCO. In Azerbaijan, around 1 million patients with migraine and 700 neurologists. And however, only 50 of them treat migraine. And just 10 of them have advanced training in headache medicine. There are no certified headache specialists and specialized centers. This means that about 20,000 migraine patients per treating neurologist and 100,000 per neurologist with headache training. As a result, only about up to 5% of people with migraine have access to specialist training in headache medicine. We conducted a nationwide survey across over 60 urban, semi-rural, and rural areas, and of more than 300 healthcare providers. This allows us to capture a representative picture of headache care in Azerbaijan. And we invited doctors from different specialties. Most of them were general practitioners, neurologists, and pediatricians. And 90% of migraine patients are seen by healthcare providers who didn't receive structured headache education due to during the medical school. And this highlights the urgent needs for training. What about patient demographics? Most of them were women, and headache was most prevalent in 18+ age group. There is strong link between income and education. And 2/3 of patients reported with high education school and below reported low income and poverty. It's especially important when we consider treatment access. And because in Azerbaijan, all migraine patients must pay for medication. And we don't have any national health policy for headache and no free access to migraine medication. Although patients reported that they could afford all medications, these statements don't relate to triptans, and affordability of triptans remains a major barrier. For acute management, the most prescribed drugs were NSAIDs and simple analgesics. And triptans prescribed only 15% of cases. But why? Because triptans are mainly expensive. They can cost up to 100 times more for one pill than simple analgesics or NSAIDs. And number of sold triptans pills in Azerbaijan in 2024 suggests that in spite of availability of triptans, only 1% of 1 million patients use them. This below percentage can be explained by two reasons. Healthcare providers underprescribe triptans due to insufficient training in headache medicine, and most patients cannot afford triptans due to high cost. In terms of preventive treatment, older and inexpensive options such as amitriptyline and magnesium dominate. The main reason for this was their low price. CGRP monoclonal antibodies, Gepants, and Gitans are not available in Azerbaijan. To summarize, key findings: there are limited access to headache specialists, insufficient training in headache diagnosis and treatment. 85% of people with migraine lack access to effective migraine medication. Low awareness and help seeking among patients. In Azerbaijan, access to evidence-based health care is still very limited. Our immediately needs are training doctors and make effective medication affordable and align health policy to contribute and support delivery. I thank the International Headache Society for its leadership on access in low and middle income countries, and Professor Rami Burstein for his support and for inviting me to share our results and situation. And I hope you will visit Azerbaijan and experience where European and Asian meet. Thank you so much for attention.
The next country is Egypt, and it will be presented by Professor Amar Hassan, who I'm sure many of you know. He's a professor of neurology at Qasr Al Aini Hospital in Cairo University. He's a member of the IHS Educational and Membership Committee and a former IHS member of the board. Please.
First of all, I would like to thank Professor Rami Burstein for involving me and involving Egypt in this very important initiative. And this is my official first slide. However, I tried to ask the AI to create an image about the headache axis in Egypt and headache care in Egyptian patients, and this was the result. So, despite it's very creative and very innovative, however, it is not very far from the reality, because the Egyptians, the old Egyptians, ancient Egyptians and pharaohs had realized headache. And as we see in this papyrus, that one of the pharaohs, he's a physician and he's treating a patient with headache by bandaging a crocodile, a clay crocodile with some herbs in its mouth, just to relieve the headache. So I believe that it was due to the bandaging itself, it could cure the headache by external compression. By the way, this papyrus is not available in Egypt. You will find it in the British Museum if you would like to see it. So Egypt is the most populous country in the Middle East and Africa. We are now about 118 million population. with good number of neurologists. We are 4,000 now. And we have like 100 headache specialists. And the estimated number of people who suffers from migraine according to the prevalence of migraine in Egypt is around 18 million patients. So the ratio is around 1 neurologist to every 5K patients and 1 headache specialist for 200K patients. In this survey, we had 321 respondents. Many of them, or majority of them, were neurologists, around 80%. The rest of them were other specialties like internal medicine and family medicine. The data here shows stark centralization of the providers in the capital, in Cairo, and in the big cities like Giza, Minya, and Fayoum. However, in contrast, the southern and border governorates are still suffering from the lack of neurologists and headache specialists. Almost 90% of the study participants assumed or reported that they had basic headache training, and around 92% of them are working in hospitals. The others are working in community-based organizations, healthcare facilities, or pharmacies. And fortunately, 17% of the patients involved in the study are having high school or postgraduate, and 25% of them are having below high school, 25% high school. Regarding the income, unfortunately, almost 1/3 of patients are below the poverty line, and around 23% are low income. So we have almost half of patients are either low income or below the poverty line, and only 12% are high income patients. Regarding the gender of patients, almost 2/3 of patients were females, and almost 2/3 of them were adults. This is very interesting here that the preferred healthcare facilities by Egyptian headache patients, almost 40% goes to private clinics. And this is a little bit some contradictory with the fact that almost 50% of population either low income or below the poverty line, because simply the fees of having a consultation at a private clinic at a very distinguished professor is very low. It could be like 10 to 20 USD. So even people with low income can visit a good professor at their private clinics. And this is matching with the health system in Egypt in general, because most of people prefer to go to private clinics or private hospitals, and then they might go to university hospitals or the Ministry of Health facilities. We reported some barriers to early diagnosis of migraine and of headache, and mainly the lack of awareness and the wrong medical information, and seeking advice from the social media or from non-professionals are among the main barriers to early diagnosis. The most prescribed medications here, as we see, are the basic medication we all know: paracetamol, topiramate, triptans. By the way, we have 3 triptans in Egypt: propranolol, NSAIDs, valproate. With the more expensive medication like venlafaxine, candesartan, it's much less. And then the most expensive medications like Botox or Gepants or Ditans are less prescribed. They are almost prescribed by a neurologist, followed by general physicians or other professionals. Unfortunately, that 80% of patients have to pay for their medication, and unfortunately, that 45% of patients do not have the ability or affordability to pay for the medications. So what are the available medications in Egypt? As we see here, we have what is here in blue means the available medications for those who can pay, and in orange for those who cannot pay. So we can find that patients who can pay and who cannot pay can find paracetamol, NSAIDs, and propranolol, amitriptyline, and topiramate. But if we go to the other side of the graph, we'll find that the more expensive medication, the more costly medications are available only for those who can pay, which means that those who cannot pay has limited access to more expensive medications. And to give you an overview about the economic situation here in Egypt, now in Egypt, we have rising GDP over the last 10 years. However, despite this rise in the GDP, we have declining monthly earning because of the devaluation of the Egyptian currency and because of the inflation. So, according to the recent figures, we can find that in March 2025, the average monthly earning for an average Egyptian citizen, not Egyptian patient, just 140 USD. This is the average income. So can you imagine if we look to the Egyptian market, the Egyptian migraine medications market, we can find here that the Egyptian medications for migraine market is around 26 million USD, which is more or less equal to United Arab Emirates. But can you imagine that United Arab Emirates is just 10 millions, while Egypt is 118 millions. So despite it's a good market, but this market is mainly formed of the cheap medications, because here we can find that fortunately, the monthly cost of the acute medications and preventive medications in Egypt can cost the patient like 2 to 3 USD to cover the whole month. And this is a good thing that the medications are available and cheap. However, if we look to the more expensive medication, Botox, galcanezumab, Remigipan, for example, we'll find they are all available in Egypt. We have 2 monoclonals, Erenumab and galcanezumab, and we have Gepan, and we have Botox as well. And the cost of Botox per month is much, much less than any other part of the world. It's around 82 USD per month. 82. However, 82 USD per month is equivalent to around 60% of the average monthly income of an Egyptian patient. So any patient, any normal average patient cannot pay 60% of his monthly earning to pay for Botox, and it costs him around 150%, which means 1.5 the monthly income just to get one single dose of galcanezumab or Erenumab. So I think the situation in Egypt is a little bit different from other low middle income countries. We have many advantages. We have the advantage of cheap medications, of cheap consultations, and we have many neurologists. However, we have our own challenges. The challenges here are many, but they are mainly in the public awareness, because many patients does not go to doctors. They seek medical advice in the pharmacies. Although neurologists are available and they are well trained, the access to specialized care is still inequitable among all the governorates. And the high cost of advanced therapies relative to average income rendered them inaccessible to the majority of patients. And despite that most of the essential medications are relatively cheap, national strategy to ensure equitable access to essential medication is still needed, because some people who are below the poverty line can not even afford the 2 to 3 USD per month to get the medications. Finally, strengthening the primary care capacity through training in headache recognition and management is critical to narrowing the treatment gap. I appreciate the IHS dedication in advancing access to headache care in low middle income countries and opportunity to represent my country, Egypt, in this important dialogue. And many thanks for Professor Rami and Professor Ainur Özgi and Professor Daria Uyudulis for being that supportive to us and to Egypt in this important initiative. And many thanks for my colleagues who helped me in this survey and this presentation. And thank you so much.
Okay, so Dr. Raviraj Timasina could not make it. As I said, he's a professor of neurology at the Gendaki Medical College Technical Hospital. He worked extensively on the Nepali adaptation of the WHO Mental Health Gap Action Program. He said this, he was extremely upset that he couldn't make it, try everything he can. I cannot possibly make the justice on presenting Nepal, so I'm gonna go through the Nepal part really quickly and highlight the few things that I think make sense to do. So this is Nepal. Several people, including Rajiv Ojha, play a critical role in making this, in completing this study. Most of the data were collected in cities and not in the rural areas. Just to give you a concept of what Nepal looks like, this is a makeshift camp in Purmuru health post in Sorowal municipality of Nepal, where there are no existing health centers. And as you can see, there's no electricity, there's no running water. They use lamps to do surgeries. Just to get you the feeling of what Nepal is. A population of just over 29 million people, so about 10 million migrant patients, neurologists, total neurologists, 36, 0 headache specialists. It basically put you in an impossible ratio of neurologists to migrant patients, and there are no headache specialists in Nepal. Who treat headache patients? 68% are not MDs and 31% are MDs. An eye-opening concept that MDs do not treat migrants, with minimal training in basic care on the diagnosis and treatment of migraine. Age population is like everything you have seen. The majority are between 25 and 50, but it is representative of all the patients. Education level of the participant, can you put the stage? Okay, is in high school and below. And I think that the thing that you need to see is the most prescribed medications are paracetamol and NSAIDs, and there is about 9% of patients who get prescription for triptans. And this may be the last point that I want to put here is the fact that while the majority of the patient pay for medication and can afford medication, this does not translate into headache medicine. Basically, when we looked at the study, out of the 10 million people that suffer from migraine, there are 140,000 pills that have been sold. The calculation is that about 1,300 people among the 10 million people get access to triptans. That's about 0.01% of the patients. With this, the concept of access to headache care that is barely exists in Nepal, and access to medication is to headache medication is nearly at zero. This is thank yous, and we're going to move to the next country. We're moving to Moldova, and our next speaker is Dr. Oksana Gruso. She's a clinician, a scientist, and the head of the research unit at the Headache Center of the Diamond German Institute of Neurology and Neurosurgery. She's a graduate of the IHS Fellowship in the Montefiore Headache Center in New York with Richard Lipton. And please, Dr.
Thank you. Ladies and gentlemen, dear colleagues, I'm very honored to be here and present my country. And I'm very grateful to the International Headache Society and Professor Rami Burstein for the opportunity to present the headache care in the Republic of Moldova. So the next, okay. Before I begin, let me mention that I have nothing to disclose. To understand the circumstances and why a European country is in this cohort of countries, I'll present a little bit about the Republic of Moldova. It's a small country in Eastern Europe. It's located between Ukraine and Romania. Historically, it belongs to Romania until it was taken over by the Russian Empire more than 200 years ago. Despite this fact, we identify ourselves as Romanian and we speak the Romanian language. As a former Soviet republic, we still carry many stigmas, a lot of outdated medical practices and harmful beliefs and attitudes. Our health system originally was built on old standards and is still undergoing continuous reform. Until 2021, Moldova was classified as lower middle income country. Since then, it has been reclassified as an upper middle income country, but the life is still difficult, mainly because of the war near the border and because of the massive migration that has cut our population in half in 30 years since independence. We do have a mandatory health insurance system and government is paying for our vulnerable population, but we don't have reimbursement for headache disorders. The headache care in the Republic of Moldova is relatively recent. Everything started in 2002 when Professor Moldovanu completed a fellowship at the Mayo Clinic with Professor David Dodik. Then it was the first epidemiological study on headaches in Moldova between 2005 and 2007, although it was unpublished. The establishment of the Headache Center in 2010, which is still functioning without funding or paid staff, sustained only by volunteer work and enthusiasm. In 2017, we approved the national clinical protocols for migraine and tension-type headaches. In 2018, it was done a national survey on the management on chronic headache and pain to find out what are the barriers in the patient management and to inform the health policy. All the specialists that are working at the headache centers have acquired their expertise through doctoral research, as there is no other national course, master program, or any form of certification in headache and pain medicine in the Republic of Moldova. We do have some young persons that have actively contributed to the research that I will present. To understand the real workload of a headache specialist in the Republic of Moldova, we do some calculations. On the slide you can see that the numbers are very high, like the number of migraine patients per neurologist is more than 1,000, and the number of patients per headache specialist is even more. With the support of the International Headache Society, we performed a nationwide survey, and we collected 212 completed and validated questionnaires. As you can see, almost half of them came from the capital city, with few of them from the northern and southern regions. This result reflects both the difference in digital access, interest in headache care, and distribution of medical staff who are more concentrated in the big urban areas. The big part of the responders were neurologists, which represent the key role in the headache care. They followed by pharmacists, who in Moldova are trained as medical doctors, but they cannot prescribe medication. Their role is to advise patients on available medication and to encourage them to go to family doctors or to neurologists for consultations. Family doctors are the first point of contact. They can order investigation, they can diagnose and prescribe treatment, but they feel unsecure and they prefer to send patients to the second-level neurologist or even to the third-level headache center. Unfortunately, in the country, there are no community or social services for headache patients developed at all. When we looked at the workplace distribution, we find out that a big part of the responders works in hospitals, then followed by pharmacies and healthcare facilities, which are the family doctor centers. This information is in collaboration with the results of the other study that we do before, and we find out that our patients like to go to the physicians in the hospital and not to go to the family doctors. Regarding education, 61% of the healthcare professionals in the survey report that they receive some basic headache care education that consists of 2 to 4 hours in medical school and then 4 to 8 hours in residency, and after graduation everything is just through conferences, congresses, webinars that are held occasionally at the national level. And I will repeat, no formal education, fellowship, master or certification. As for patients, physicians report that the most cases were women and they were adults over the age of 25. This reflects a little bit general data, but there is a cultural aspect in the Republic of Moldova that patients are not seeking medical help until the pain is too severe. Another important aspect is the socio-economic. So national and international statistics show that almost 30% of the population are living on less than $3 per day, which is at the poverty line. Our results suggest the same numbers. And this economic hardship, of course, reflects the prescribing of medication. And as you can see, the physicians prescribe most the medication that are cheaper, widely available, and they are already known for them. And you can see that there are NSAIDs. Only 14% of the physicians prescribe triptans, and this reflects the low availability of the treatments on the market and the low awareness of the doctors about this medication. Another important barrier in the management of headache patients in the Republic of Moldova is the access to treatment. Our survey shows that 41% of the patients pay out of pocket for the medication, and this medication, there are no triptans, they are NSAIDs. And even 36% of them cannot afford them at all. So, in summary, you can see that the Republic of Moldova faces a lot of challenges in headache care, like limited resources, limited access to modern therapy, and lack of education. But I think there is a hope, because our small team continue to work, continue to build expertise, conduct studies, and advocate for better care for our patients. And we strongly believe that international collaboration, knowledge exchange, and solidarity could help us to bridge this gap and bring the headache care closer to our patients. On behalf of my colleagues and my country, I thank you for your attention and for taking Moldova in this global community. Thank you.
Okay, we are getting to the last few countries. The next country is Mexico. It will be presented by Agustin Melo Carrillo, who is now an assistant professor at Harvard Medical School, but he is originally from Mexico, and his entire education was in Mexico. Please.
Hello. Well, first I would like to thank the International Headache Society for including my country into this big project. It's really an honor to be here talking about it. But even though I'm the one talking, this was a really big effort that included a lot of people. It's a big team that involved a lot of people from the Mexican Headache Society, Fundación BEST, which I'm going to talk later about it, and also people from our lab. So in order to prepare for this task, we actually developed a small pilot study where we asked headache specialists from the Mexican Headache Society to interview patients that they were seeing for the first time in their clinic, and the patients were coming to them for the first time to a headache specialist. These patients were all diagnosed with migraine with or without aura, and this is what we found. We found that they suffer from migraine for an average of 17 years without ever seeing a headache specialist. This was in 156 patients, sorry. They had an average of 8 days per month and 4 migraine days per month. During the 17 years of suffering from undiagnosed headache, they were treated mainly by general practitioners and rarely by general neurologists. These 156 patients are well educated. 72% of them have college degree or higher, and their socioeconomic status is in the middle or higher range. What did they get prescribed by non-headache specialists before reaching to the headache specialist is mostly acetaminophen and NSAIDs. And you can see that less than 10% of them actually reporting getting any medication specific to migraine, in this case, L-triptan. And one of the things that we actually notice also is that they use a lot of opioids, and for some reason, opioids, at least one of them, tramadol, is actually over the counter in Mexico, so they can get it freely, and they use it a lot. One of the most striking data that we found in this small pilot study is that in Mexico, patients do not miss working days, social events, or family activities due to migraine. They're reporting only missing 1 day per month for work, 1 day per month for social activities, and only 2 days per month for performing home duties. And they all, over and over, said mainly 2 things. First, their employers do not believe that headaches can be so painful and debilitating in order for them not to come to work. So in this reality, patients who do not come to work are likely to be terminated or go unpaid for several days. The second is that the family construct and tradition in Mexico is where wives are responsible for all home duties, including preparing food, cleaning the house, raising the children, etc., whereas the husband are responsible for providing the income. So mothers actually just go and do what they have to do in both cases. The problem with this pilot study is that we are sampling patients in headache clinics, and is that the data that represent the most privileged part of the society, which tends to be a very small minority, at least in Mexico. So in order to solve this approach, what we did is we created a partnership between the International Headache Society, AMSEMIC, which is a Mexican Headache Society, and Fundación BEST, which is an affordable private healthcare system established in 1994 in Mexico to care for the poor. This allows patients to be seen for just paying $4 per consultation. And all of them are seen by at least an MD without residency. Now, we use an IHS designed headache survey for healthcare providers, and we send it through the Fundación BEST health system. This is 15,000 medical offices of primary care physicians, mostly MDs without residency, working in these urgent care facilities. The responses were completed by 5,857 of those primary care physicians that work in this Fundación. We were very lucky to get input from all the states in my country, and also we got an even distribution between urban and rural, which was very important for the purpose of this project. So what is the providers to patient ratio in Mexico? The population size in Mexico is actually 130 million people. We have around 1,800 neurologists and around 83 headache specialists. Reported by the Department of Health, we have a 15% of people that suffer from migraine. That accounts to 19 million people. So the ratio is basically 1 neurologist per 10,555 migraine patients and 1 headache specialist per 228,000 migraine patients. And who sees the patients and treats the patient with headache in Mexico? 88% are treated by general practitioners, and only 12% get access to actually seeing a neurologist, even if he has a degree to training to treat a headache or not. So the people who actually filled our survey, 88% of them were MDs without a residency, 7% of them were MDs with residency, and the rest of them were MDs with some sort of certification, diploma, or a master or a PhD degree. But none of them who filled the survey received appropriate training in basic headache care. So with all these numbers, what we found out is that the 5,857 healthcare providers who filled the survey reported seeing 3.6 million patients per month. Of those, 592,000 complain about headache. If we take into account the whole healthcare system from Fundación Best, we can say that they see around 9.4 million patients per month, and of those, at least they see 1.3 million patients with headache per month. So this is a population that we might be able to help with what we want to achieve. Now, this is actually the reality in my country, which is it was a good thing that we achieved with this study. Now, all our patients were in the middle or low socioeconomic status. The education level of the patients goes mostly from elementary to high school. Like 62% of the patients who actually come to this healthcare system are female. And the range of age goes from 0 to 64, mostly being the most common from 15 years to 44, but they also see a lot of pediatrics patients, as you can see in the graph. It was also reported by all the healthcare providers that 82% of the patients can actually pay for the medication. So what do they get prescribed? 99% of the medications prescribed for people in this healthcare system with headache are mostly NSAIDs and paracetamol. Less than 1% are triptans. And you can see we divided the survey into 3 things: medication prescribed for headache in general, medication prescribed for headache for patients who can pay, and medication prescribed for headache patients who cannot pay. And you see the same trend. They all get prescribed paracetamol and NSAIDs. In the people who cannot pay, it's a little bit more, but regardless, the medication specific for headache is not even at the top. And as you can see, tramadol is in the list again. The price for the pills is actually not that expensive. It's for the 50 milligram sumatriptan pill, it's $2, and the sumatriptan 100 milligram is $3.7. So what we found in this survey is actually that it's not so much that the patients don't have access to the medication, but it's the training that the primary care physicians receive that is not enough to actually seeing all these type of patients. So this study provides a deeper understanding of the epidemiological trends of Mexico, the migraine in Mexico, with the objective of improving healthcare outcomes and enhancing the quality of life of patients with migraine nationwide. Based on these findings, we actually developed an online course aimed at the continuing medical education of primary care physicians in Fundación Best, with the goal of strengthening the management of headache disorders in primary care settings. So again, I would like to thank the International Headache Society for this opportunity. It was really an honor to participate in this, and to thank Dr. Burstein for including me. Thank you so much.
Okay, so as I said before, the Dr. Odgo Beyer, Professor Nerov from Mongolia could not attend, so I'm going to go. I cannot do justice by presenting her data, so I'm just going to go through the highlight very quickly and move to Kenya. No conflict of interest. This is who she is, Professor Consultant of Neurology in the Mongolian National University of Medical Sciences. Multiple people have worked with her on this project, the headache project. As you can see, most of the data came from the capital, from Ulaanbaatar. Briefly, population 3.5 million, estimated number of neurologists 380, no headache specialists, estimated number of adults who suffer from migraine, 450,000. It means one neurologist per 10,000 people. Epidemiology, 24% of the adults have migraine, tension-type headache, 29%. The healthcare providers who provide the data, the minority are neurologists, and they work in hospital if they're in a city, and they work in community health-based centers if they're not in a city. 50% of them went to medical school, the other did not. And here's the numbers. 89% of medical doctors and pharmacists who participated in the study reported getting some headache education, which is 1 hour lecture in medical school and 4 hour practice in headache basic care. 12% of the treating are neurologists with 4 hour seminar and 6 hours practice. The economic level is below poverty or at low income for about 50% of the population, and below poverty is less than $30 per month. Low income is $125 per month, and what it translates is the following. Triptans are prescribed to 5% of the patients. Ability to pay is for about 45% of the patient. However, the first triptan, rizatriptan, was introduced in Mongolia in 2023. It cost $8.86. As we looked at the industry, the number of patients using Maxelt in Mongolia is 150 patients out of 450,000. That is 0.0% of the patients. So the summary is similar to what you heard in different countries. There are no headache specialists. Rizatriptan is out of reach for anyone but less than 1% of the population. So the conclusion is that access to specific migraine medication is essential. It virtually does not exist, and we need to train people in headache medicine. I'm going to stop here and move to the next part. Can you do that? I'm going to cut it short in order to get to the 4 o'clock and be done and finish it. So overcoming barrier to headache care, and as you can imagine, although, if you want. So we cannot start fixing the whole world in one shot. So what we did is a story of gathering facts about patient access to headache care treatment across the globe, determining how to address the barrier we found, and initiate a comprehensive approach in 3 countries, in Kenya, the Philippines, and Mexico. So I did not present to you Kenya. It's the only country I'll present and not summarize. In Kenya, we started with an organization called IHS Clinic, with a healthcare provider called Edwin Wara, who is a clinical officer. We never met MDs in Kenya. And here, these are the people in the IHS Clinic. And here is the survey. We ran a survey in 221 clinics in 55 counties that spread throughout Kenya, mostly in Western Kenya, which is the rural and the poorer part of Kenya. Just to give you a little bit more life into this conference, where the few of you have stayed here, is that the living condition in Western Kenya are the fact that you can drive for hours and hours and not see people at home, because most of the people don't have electricity and don't have running water. They really live in the streets. And by far the most important part that they need is clean water. And the yellow thing that you see is really clean water. And this is how to transport people around. Who treat the 7 million headache patients in Kenya? Headache specialists, none. There are 11 neurologists in the country, over 56 million people. This is one neurologist per 636,000 people. Only 0.4% of the patients in Kenya see MD. MDs, 99%, are treated by clinical officer, nurses, and community health workers. These are people with high school education, the last group. Level of healthcare facilities that they go, there are 6 levels. Level 1, 2, 3, and 4 has no MDs, there has nurses. At level 1, nurses and one clinical officer. Level 2, few clinical officers, and level 3 and 4. In other words, headache patients are not seen in facilities that have medical doctors. Reality in public healthcare facilities in Western Kenya, if you want to look at it, no running water, no electricity in most healthcare facilities that we visited. We visited maybe 12 or 15 facilities and met one MD in Nairobi. In other places you can't find MDs. Patients don't know what is a neurologist, what is a pediatrician, what is a gynecologist. They just are not familiar with this terminology. And with this concept that the refrigerator has medication, but they're not plugged because there's no electricity, it is the reality that we met in Kenya. Now, it's not true all over. If you go to Nairobi and you get to faith-based health facilities that belong to the Catholic Church, the medicine is better. They do have electricity and they have a little bit more advanced ability to care for patients, although the patients are still not seen by MDs. So medication used for migraine in Kenya, sumatriptan is used by 0.4% of the patient. Paracetamol and ibuprofen and diclofenac and tramadol lead the way, like in all countries that you have seen. Now, I'm going to go really quickly through my take home from the Philippines. And I think that when you go to Manila, things look different. When you go to rural areas, living conditions are challenging to a large number of the population. What you heard is that who treat the 20 million people with migraine. With 17 headache specialists, it's one headache specialist per 1.2 million people. And the rest of it you heard from Dr. McAlintal. So I'm just showing you what I have seen on patient waiting room in different islands of the Philippines, just to give you the concept on how few healthcare providers that care for neurology patients exist. This is what the proportion is translated into. So I'm gonna move. Instead of repeating it, I'm moving to. Let me go to the end of it and take you into a summary of the included countries. So more than 95% of all migrant patients who live in low, middle-income countries will not see an MD for their headache. This is something we need to figure out. One MD with basic training in headache care is available for caring for 536 million people, almost 500,000 people, one neurologist for 16,000. And in the absence of MDs, those who treat migrant patients in many countries are clinical officers, nurses, midwives, pharmacists, and community healthcare workers. I'll tell you about them in a minute. And triptans, overall, when you take all the patients that were included in what we did, are used by 0.5% of the 59 million patients in the combined countries that we studied. The other 99.5 use paracetamol, NSAIDs, and combination of paracetamol, NSAIDs, and caffeine. And the reason is healthcare providers are unaware of triptans. And think about it, 4 years after their introduction to Europe and the US, triptans are still beyond the reach of nearly all migrant patients in the world. So defining the problem in low middle income countries is the fact that only 1% will see MD with basic training and care, and only 0.5% can afford triptans. And the question is, how do we solve it? So here is where we go. Creating access to the care requires education of non-MD healthcare providers and enough medications and awareness among patients and advocacy to national and international health ministries and health organizations. So, from defining solution to on-the-ground implementation, and this is a practical plan of action 3 years after we started to work on that. So the first thing that I'm gonna claim here is that we cannot do it alone. With the principle that if we try to do it alone, we go fast, and if we want to go far, we need to go together. So together means partnering with whoever we can. These are an example of our partners in the Addis Clinic in Kenya. These are our partnership that we created in Kenya with the Ministries of Health for the national government, Minister of Health in counties that we visited, and with the ministers or the officer that's responsible for the Office of Non-Communicable Diseases. More partners in Kenya are faith-based organizations, the Trust of the Kenyan Conference of the Catholic Bishops, that run most of the medical network in Kenya, the Christian Health Association of Kenya, and the Mission of Essential Drugs and Supply. These are really those who supply the drugs. It was an experience to find myself talking to 500 bishops and priests who are in the world of medicine, and to see that these are the people that will open the door for us to treat migrant patients. In the Philippines, we are in the process of establishing partnership with the Philippine Neurological Association, the Philippine Headache Society, Department of Health, local government units, doctors to the barriers Association of the Municipal Health Officers, and the Philippine Society of Public Health Physicians. Okay, so I'm putting for you something that is novel to all of us, and this is the power of the church not only in Kenya, but also in the Philippines. In addition, I'm showing you the power of partnership, the importance of partnership in rural Philippines. So we just realized how much power and influence mayors and local government have in establishing healthcare facilities in the most remote islands of the Philippines. And the message here, the more we partner with, the better chance we have to make a difference. When you heard the last lecture, think about it. By maximizing education outreach through collaboration in Mexico, can only happen with the association with the Mexican Headache Society, with Foundation BEST, and with Pharmacia Similares. This is an access to 15,000 healthcare providers for MDs without residency, who see millions and millions and millions of patients, and you saw the numbers, that how many patients they see per year and per month. So, education part one, thinking big. And thinking big means establishing infrastructure for educating tens of thousands of healthcare providers, and not small number and opportunities in small places. So here we present a challenge of shifting focus of education. So as you know, we are all very good at educating neurologists, headache specialists about diagnosis and treatment of migraine. Right, 4 years medical school, 4 years pre-med or 4 years medical school, or 8 in different countries, 4 years residency, 1 year's fellowship in order to diagnose migraine. And the question is, can we find ways to educate non-MD healthcare providers, such as clinical officers, 4-year medical education, non-medical school, nurses, 4 years medical education, community health workers, no medical education, midwife and pharmacists about diagnosis and treatment of migraine at level appropriate to their background. So, setting the stage for educating clinical officer and nurses. I mean, these are all clinical officer and nurses. They are nuns, they are nurses, they are bishops, they are priests, and they are clinical officers, and their outreach in the community is huge. So now, doing all of that is never going to work in these countries if you don't bring the patient to the clinic. The bridge between the patient and the clinic is community health promoters or community health workers, which exist in many countries. I don't know how many of you are familiar with it. So these are high school education. Many of them are farmers who work half day in the farm, and the second half of the day, they ride their bike from village to village. Each community health worker oversees 100 families, about 1,000 patients. They are the one who go into the home, listen to patients, telling them what bothers them, and know enough to tell them whether what they have is treatable and to take them to the right healthcare facilities. And without telling them about headache, without teaching them, we are losing the opportunity to actually take the patient from the home and bring them to the clinic. Working just in Kenya with community health workers give us an outreach to 65,000 community workers in one shot, if we can find a way to educate them. In the Philippines, it's different. There are headache specialists that can do the work for us, and there is a residency program, maybe not in all islands, but in many islands. And here you can see Dr. McClintal. Look at, there are 240,000 community health workers in the Philippines. And if they are called barangay healthcare workers, not MDs with high school education, if we can reach out to them, we have a huge tool to get all these patients into the clinics. It is the same in Kenya. The barangay healthcare workers and midwives that are the bridge, and there are ways to educate them. And in addition, of course, there's the IHS training and headache medicine program that provide healthcare to both. You see here our program of a nurse from Kenya, work with Dr. Metzger in Buffalo, and neurology and pediatric neurologist from the Philippines who's working in the Cincinnati Children's Hospital. So the power of working with local partners in Kenya really give us an opportunity to educate 15,000 primary care physicians. We see 1.26 million headache patients per month. And if we want to make a difference, we have to think about ways that we can partner with those who can bring millions and millions of people to the clinic so we can help them correctly. The second part is thinking smart. So how do we develop educational tool that fits the background of clinical officers, nurses, and community health workers? So here I give all the credit to the education and child and adolescent committees of the International Headache Society. Many of them have put together the concept of how we're going to educate these people who are not medical doctors. So I'm going to give you just a few examples beside the syllabus that we're putting together. So here are flyers designed to help clinical officer and nurses to diagnose migraine. Basically, it's the ID migraine and the 8 questionnaires with images that allow patients that allow clinical officers and nurses to diagnose migraine correctly. Flyers that we put in this clinic, designed to help them to differentiate between primary and secondary headaches in the simplest possible way, and of course flyers that are designed to help them treat with medication that are available in their countries, and just you can assume that currently triptans do not exist. And if they exist, we need to introduce it. Flyers that are designed to help community health workers to recognize migraine, not to diagnose it, is to just take it into patient's home and show them pictures and figure out if any of those are photos that they can identify and recognize as something that resembles the kind of headache that they have. And eventually, we are working with the Child and Adolescent Committee to put together flyers that help pediatric clinical officers, right? Basically, the difference is in the Western world, nurses and clinical officers work under the supervision of MDs, but in countries like Kenya, for example, they do not. They work independently. There is no MD supervision. So any education that they need to get is what they need to get. They're not going to have anybody to go and ask questions. So it is the principle of how we would like to simplify medicine and assume that you don't need to go through 13 years of medical training to be able to diagnose migraine, that there must be a way to be able to diagnose migraine in a way that is simpler than what you all go so to become headache specialist. All of it will only work if we can provide medication. In the absence of medication, none of it will really make a difference. So we focus on sumatriptan because until today, it is the only headache medication that is found on the essential medication list of the WHO. It makes sense. It's what we hear from government, from health ministers in government. This is what we should do. So sumatriptan is the only migraine on the essential medication list. Worldwide, sumatriptan and its class of drugs is the most prescribed migraine drug. It also has the highest strength of evidence for efficacy. It was approved first 40 years ago, and although it became generic almost more than 15 years ago, it is used by less than 1% of the people in the world. And the key reason is price and lack of awareness among providers for triptans. So let me just give you quickly the economy of sumatriptan. In Kenya, 31 million people earn less than 50 cents, between 50 cents and $1.50 per day. Monthly cost of sumatriptan is $14. In the Philippines, 69 million people, 63%, earn less than $3 per day, and the monthly cost of sumatriptan is between $16 and $32. In Mexico, 66.7% of the population earn less than $4 a day, and at $2 to $5 a pill, the monthly cost of sumatriptan is between $16 and $40. If you look at Mongolia, 27% of the population earn less than $1 a day, low income 31%, monthly cost of sumatriptan, $91. You go to Nepal, below poverty line, 20.7% of the patient earning less than $2 a day, and low income is 47%, monthly cost of sumatriptan, $8 a day. You understand that with this economy, patients cannot have access to sumatriptan, even though it's generic for 15 years. So where did we move from here? We understood at that point that we need to create a charity that is based on philanthropic money, like the Gates Foundation, that will allow us to raise enough money to purchase enough medication to treat 100,000 patients in several countries with the same information. There's nothing magic about, there is something really magic about 100,000 patients that we want to treat by people who we educate. The goal is the following. In most governments, there is a basket of medication that are given for communicable diseases or non-communicable diseases like diabetes, hypertension, family planning. Medication for this are given for free by the government. Why can't they do it for migraine? They can't do it if we don't provide data on 100,000 patients, that even if clinical officer and nurses diagnose and treat them and give them triptans, the patient can still go to work and function at home, and kids go to school. So we created an organization called Global Migraine Aid, with someone who has migraine-like headache for about 8 years, any time of the day that he's awake, and no headache doctor was able to help him, and with a lot of motivation, helped me put together this US charity that allows to raise money to do it. The second one is how do we do it? So Global Migraine Aid works with a healthcare provider that deliver the medication for free to communities in need. In Kenya, for example, it's the Kenyan Council of Catholic Bishops. And to do that, guess what? The cost of creating one sumatriptan pill is between 1 and 2 cents. So if you can negotiate to less than 10 cents or less than 15 cents, now it gets to about the price of paracetamol and NSAIDs, which patients should be able to pay even if nobody is buying it. So we negotiated with NGOs that work mostly with suppliers in India, and we were able to drop the cost to 15 cents a pill. It's not where we hope to stop. We hope to stop at less than 10 cents a pill. We're now at 14 cents a pill. So the reason I explained to you, it's important because it's the only way to create sustainability by us finishing these studies in several countries and then have an agreement with the Health Ministry, National Health Ministry, that they will take over if the results of our studies are successful. Okay, all of this is okay, but if we don't bring the patient to the clinic, it's not going to work. So I'm putting for you patient awareness. So the definition is simple. In the context of headache, awareness means accurate knowledge of person experiencing headache needs in order to seek help from healthcare providers. So the knowledge is about recognizing your headache, knowing that it is treatable, that your headache may interfere with your life, that your headache is not a punishment, and that you don't need to feel ashamed. And the goal is to convince a person suffering from headache to seek help, to reduce suffering, and to reduce negative impact. So again, how do we do it? We cannot do it alone. We can only do it through partnership to reach broad reach. So I'm giving you an example. The Kenyan Council of Catholic Bishops, where I've done most of the work, has an opportunity to treat 10 million people who seek comfort in Catholic Church every Sunday. We also have partnership with education ministries and schools networks. So there's an opportunity to reach about 7 million children and adolescents attending Catholic-owned, sponsored primary, secondary, and tertiary boarding schools. An opportunity to include their parents and teachers in this awareness. So where am I going here? So basically think about it. The first place where I landed is in the Catholic Church. And the reason is because it started with people in Africa who told us that people who suffer from headache and have no medical help go and seek the priest help and commonly comfort themselves through prayers. Look at the numbers, 256 million Catholic in Africa, 425 million Catholic in Latin America. In many of these countries, 70% of the population go to church every Sunday. So if we partner with the Catholic Church, which I'm giving you only one face and one system as an example, we can work it. Slowly, we made our way into convincing priests within this Catholic Church to add 1 or 2 sentences about migraine on Sunday service and to use flyers to advertise for their patients to try to recognize that their headache is treatable. and the flyer is really based on ID migrant on the top. It is now translated to Spanish, to Swahili, to Filipino in countries that we would like to work through the Catholic Church because it is so powerful. And I'm giving you the Catholic Church because this is who I worked with. I assume that the same concept can apply to other faiths, to Hindus, to temples, to other faiths, where we can catch a large number of people if we work with faith-based organization. And eventually flyer that designed to increase awareness about migrant among church goers that will look like this, and raising awareness through public, private, and faith-based boarding school is a huge project that we work with the child and adolescent community with flyers that really fit children's needs. And just remember, these are our partners. Look at the number, 500 heads of schools, 60 heads of institutions, 1,500 principals of secondary schools, 800 healthcare of primary school. All of them promised us to bring teachers and parents into this education. So basically we start with education, not at the end, but at the beginning, in primary, secondary, and tertiary school. So very early in life, we let them know about headache and headaches that are treatable. This is where we try to go in awareness now. So scaling these approaches to raising awareness beyond Kenya, can this approach be useful with patients attending different religious entities and children attending different school systems? And how to measure it? Clearly, all of it is useless if we don't have an outcome measure that look at how many kids from all these, how many people from all these places, schools, and faith organization come to healthcare facilities and seek help, and what is the outcome of that. The last part is advocacy, in the last few slides. So advocacy for the right of those who suffer from headache to get access to healthcare providers. In the context of migrant advocacy means actively supporting and promoting the rights, needs, and well-being of individuals and communities who face systemic barriers and disadvantages in accessing trained healthcare providers and most effective medications. So, reality check. If the IHS doesn't advocate for the right of children who suffer from headache, who will? Look at that. This is an email that I got, that we got from UNICEF in the Philippines after checking with UNICEF, which we try to approach. Good day, please accept our apology, whatever. UNICEF and partners do not work on the particular issue of headache among children. It is currently not among the priority of non-communicable diseases among children. This particular concern is also not among the many priorities, the prevention that UNICEF addresses for education. If we don't try to help them, who will? Clearly, UNICEF is not interested. So I'm giving you one more example. So in Kenya, there is tremendous amount of teenage pregnancy that come to deliver babies starting at age 13, and many of them are left alone, no husbands, and they are basically single women or widowers with almost no rights to go to any healthcare facilities or to school or to churches. And here is a note that I got. Women like me have no value except humiliating names. Widows therefore remain invisible, afraid, and with no support for or opportunities. They endure daily harmful cultural practices and too often live in object poverty. There are more than 4 million widows in Kenya seeking recognition, acceptance, protection, and allocation. Guess what? The first thing that we learn is that if we want to do studies in healthcare facility in Kenya, they are not allowed to participate in that. So the question is, if the IHS doesn't advocate for them, for the right of these women, for example, who will? And I claim here that it is our job to do that. So eventually advocacy for the right of those who suffer from a headache to get appropriate medication is something that I talked about. And one of the interesting things that we learn in Kenya is if you want to do it, you have to convince us that migraine should be listed should be added to the list of non-communicable diseases, which is one of the education committee of the IHS is working on. And once we can get that in, we have a chance to have the Kenyan government, for example, willing to purchase for the 15 cents a pill and to give it for free for migraine patients. This is advocacy. It's a big-time advocacy that starts in the government and in the non-communicable diseases. And I think that the lesson here is that advocacy starts in the government, in example, the Philippines government health ministry, in the Kenyan government, we had a meeting in Brasilia with representative of the health ministry, and the advocacy for migraine patients by partnering with Department of Health. For example, Philippine Society of Public Health, I gave you the list before, and the goals is really simple. So this really takes us from philanthropy to sustainability, where sustainability can be guaranteed only by using an approach that transfers responsibility to the country's healthcare system and not try to do it forever because we simply cannot do it. And pursuing government to add migraine medication to the list of drugs has to be based on showing the impact of our work. I'm going to stop here by just giving you a concept. I put together, there are more than 150 people who worked with me in the different countries on this project. The concept is no one can do it alone. I cannot do it alone. The IHS cannot do it alone. We have to do it with partners. And I'm going to close it with just remind you my promise that I made in 2020 when I asked you to let me be the president of the IHS. I wrote then things that I didn't know, but I know now. So I wrote on the need to preserve fairness and justice. I wrote, in fact, in many countries, headache medicine is simply not available, and sufferers can live their entire lives without ever seeing a headache doctor or receiving treatment that is affordable and can help ease their pain. The need to make headache medicine available throughout the world is an urgent global mission we should all commit to. It cannot be achieved without stronger political pressure on policymakers, health ministries, drug makers, funding agencies, and philanthropists. As better medication are introduced, this issue must become our top priority. It is a battle we cannot lose. If elected, I'll make it a top priority of my presidency. That is my presidential symposium. Thanks for staying and listening. I appreciate you all being here and giving us the attention.